short, very short time. Thank you very, very much all for finding time to join this presentation. I know that global health and international exchange is of high importance to us, and we are glad that you're here. And we know that you could be at the employee lunch, having lunch, but you chose to spend your lunch time with us. And thank you very much for that. Without much ado, we have quite a good number of things. Dr. Kim Trujillo came, but they would have some presentations afterward. But it is my pleasure at this time to introduce Dr. Jessica Everett, our speaker for today. Dr. Everett straddles international education and the medical profession. She served as the CFHI Executive Director from 2013 to 2021 and is currently the CFHI's Global Medical Director. You know, I would give you some time to read through, but most importantly, Dr. Everett is faculty in the Department of Family and Community Medicine at the University of California, San Francisco, where she instructs in global health and community-based underserved care and how under the community-based underserved care and helped develop as well as completed the Global Health Clinical Scholars Residency track. She is a graduate of the Ohio State University College of Medicine and is a longtime advocate of health-related international education quality and ethical standards. She's an author and an editor of multiple chapters, articles, and books on global health with a focus on education, ethics, and asset-based management. Dr. Everett, that is a mouthful. Well, you must have been very busy and remain very busy. Over to you. Thank you very much.
Thank you, Dr. Ekuwintan, and thank you, everybody. I want to recognize Kim Conley's work in arranging this, and just want to commend the whole institution for creating these spaces. Today, we are going to talk about not just walking our talk, but leaping our talk. And I want to kind of wrap our heads around why we have challenges walking the talk of global health, and then some remedies, particularly fair trade learning. We all probably hold our own definitions of global health, and there are different formal definitions. This is one that's often cited that was published in The Lancet in 2009, which categorizes global health as a study of a field of study, research, and practice that places a priority of achieving equity in health for all people. Global health involves multiple disciplines within and beyond the health sciences, which is a way of saying that it is an intersection of public health and clinical medicine, the synthesis of population-based prevention, individual clinical care, and promoting interdisciplinary collaboration, emphasizing transnational health issues and determinants. I would say this definition to me is a goal, and it was actually conceived of at a 2008 meeting of the Consortium of Universities for Global Health. Copland, who was a lead author on this collaborative paper, was actually at Emory University. Global health, as you know, often involves relationships between institutions and individuals that are in different realities. I'm coming from both an academic framework at UCSF, but also a nonprofit organization, Child Family Health International, which has partnerships in 10 countries, facilitating experiential global health for students and academic partners, of which KUMC is one of them. And so as such, we are confronting what these different frame of references do and the dynamics of them. A lesser known definition of global health was actually proposed at the same meeting as the Lancet definition, but did not make it into the Lancet. And so I want to highlight this definition. It was that global health is a concept fabricated by developed countries to explain what is regular practice in developing nations. That definition was put forth by a Kenyan colleague. And when I reflect on these definitions, one of the words that jumps out at me in the second definition is fabricated. And I want to explore a little bit more about how this fabrication happens and what it looks like. An analogy I would have for this fabrication is Dr. Barbie versus real Barbie. So you have Dr. Barbie here, and I can confidently say that I have never looked anything like this when I've been rounding on the wards. Definitely not wearing platform heels with open toes, definitely not carrying babies around with my stethoscope in my ears with a mini skirt on. But that's the imagery of Dr. Barbie, of what a doctor is, if you ask the Mattel company. Then you have images on the right-hand side of the screen of actual doctors. And you can see that you get very different implications based on what imagery you have. And that Mattel has created a fabrication based on a variety of different, probably considerations, including sales and a variety of Barbie-esque approaches. Not the movie, but the doll. And so this is a fabrication. Another fabrication that maybe is a little closer to global health is Savior Barbie. And I don't know if anyone is familiar with Savior Barbie. Savior Barbie is an Instagram phenomenon, and you can Google it. But these are fabrications, but also actually the images probably look fairly familiar. And why do they look familiar? Because these are similar images as many people take when they are doing quote unquote global health activities, programs, experiences. And as the wording suggests, there is a certain saviorism complex that is trying to be highlighted by this Instagram movement. And in imagery that happens in global health and in international development and volunteering. These images are not just images, there are actually harms that happen as a result of global health, which occurs in ways that are not ideal and are not walking our talk. Our goals in global health engagement and activities is not to harm patients, but in fact, that is what happens when programs and activities are poorly designed. So these are some examples of harms that happen to patients when students did not have sufficient supervision or were given responsibilities that are outside their scope of expertise, including death of an infant, 20+ patients that weren't diagnosed with malaria, child put through a spinal tap by an inexperienced student that delayed a diagnosis. That was actually something I did on a poorly designed program as a first-year medical student. Students writing prescriptions for doses that are 100 times what is appropriate. Students pulling on breech babies during birth, which, as you know, if you pull on breech babies during birth, it stimulates them and creates asphyxia and death of the infant. Multiple needle sticks happening when it would only require one if it was done under expertise, and pop-up clinics that are dispensing medications without appropriate oversight and follow-up. This phenomenon also happens for licensed doctors, nurses, practitioners. This is a study we did with Northwestern University that looked at the extent, nature, and consequences of licensed folks from the US who go to low and middle income countries who are practicing outside their scope of training or outside their scope of practice. And so there's some qualitative quotes on there, but what we found is that over 60% of professionals who go abroad are asked to do things that are outside their scope of training or scope of practice. And 50% of those actually end up saying yes to doing those things. And again, if we look back at our ideals for what global health is, it's achieving health equity. And as health professionals, you understand that sending people as the solutions who are not well equipped to practice or to do leadership or to develop projects doesn't actually serve the purpose of equity, and in actuality perpetuates inequities and is wasted opportunities. So this data comes from not only students, but also practitioners. So my question for you, and I'm hoping that we can have a conversation, but I would love for anyone who has ever fallen for a fabrication of reality, um, if that falls in the realm of global health, that would be excellent. But how have you fallen for a fabrication of reality, or how can you identify with the fabrications I've been discussing? Feel free to unmute or if you feel more comfortable putting things in the chat, but it would be great to hear from anyone who wants to speak up.
I think, thank you. That's very nice for you to come and provide this. I think one of the problems for like medical missions I see is like there is a savior mentality among the place that people go. Like when in my country they call whites nechu because they have this mentality that an educated Black physician versus who just is white and you know maybe doesn't have the qualification or so forth, they would rather be seen and be treated by that person. And that actually falls into the arena of fabricating that anybody white would be able to give healing, if you will. So and I've seen the like medical missions going in, going into a patient office or arena and probably set aside everything else and everybody focus on that mission. And the aftermath is always what the primary providers have to take the slack on. And you can see that sometimes they just don't feel that they're getting what they need from the physicians that actually work in the local area. So
Thank you. I appreciate that. And I appreciate you pointing out that this is not just in the minds of those who are going somewhere that's less resourced or differently resourced, but it's multidimensional in terms of who holds these perspectives and misunderstandings, really. Other thoughts or reflections?
One of the fabrications that I heard once, and we had some partners also participating in the presentation. It was like a Zoom discussion and presentation by students who had been to another country, and the host was on the Zoom, and the student commented on cultural norms of babies, sleeping with parents, and was very critical, openly critical. And I think that fabrication is the belief that whatever we have, whatever we promote as the way is the best way, and not realizing there are other ways that work around the world.
And I think the other thing I wanted to say was, as Kim alluded to, I was in a trip with Dr. Headings, and I liked how he tried to make it that we are there not for a fabrication of reality. It's like a two-way run. He always took a backseat, wanted to hear what the actual team has to say, and when they asked his opinion, he was also always appreciative of how complex of a situation that they work on, how they make the best out of the situation. So it's nice to see that, although there is this fabrication of reality, there are many who are really cognizant of the fact that it's more bi-directional rather than just one direction.
That's an excellent segue to furthering the discussion. When I think about what talk are we walking or what talk are we leaping, I really appreciate this graphic, which is out of Canada, out of postgraduate medical education in Canada. And they have global health expert. I know expert is probably not something that anyone's comfortable saying they are, but you could substitute that with trainee or faculty. They have the petals, the white petals are different roles we play. The blue boxes with arrows are different ways that we develop ourselves professionally and personally. But what I want to attract your attention to is the outside values and principles that are really scoring and should be penetrating all these activities and all these roles, which if you read them, health equity, social justice, solidarity, reciprocity, responsiveness and accountability, respect, honesty and openness, humility, sustainability. And when you think of Dr. Abebe's example of medical missions coming in and kind of taking over the focus, pushing aside other things that are happening on a longitudinal basis, and then doing something, and patients thinking that they are better than local providers, and then leaving this like aftermath that the local physicians have to clean up and deal with. You can trace that like these values and principles are not necessarily being lived, right? That's not responsive and accountable. That's not honest and open. There's not a lot of humility there. There's not recognition of how explicit humility has to be by outsiders who are coming with power and privilege because of the color of their skin or their accent or where they're coming from. So it's easy to say we're doing global health. It's a lot harder to hold ourselves accountable to this walk and to really dig deep into how we go off base and how do we go off target. So I wanted to kind of give us some language and some constructs to think about what gets in our way from these ideals. And the 4 things I'm going to discuss are a deficit orientation, something called the oversimplification cause fallacy, task-oriented culture, and misinterpretation of what's helpful. So one thing that I've noticed as I've kind of dug into this work over 20 years is that there is a psychological process that is happening because things look different than we're used to. And our brain makes conclusions based on things looking different and judgments and things that we have and things that we have learned and been socialized to. So for instance, health systems in many low and middle income countries, although they're working extremely well for the amount of money that is spent per patient, look very rudimentary to outsiders who are used to seeing buildings like those on the right side of your screen, that have glass and clock towers and formal, signage. And so the health systems on the left, if you land somewhere and things look different, you can make judgments that they're not working, that they don't exist. The bottom left picture, I don't know if anyone knows what those are, but those are community health workers, which are also called village health workers. They go by about 30 different names depending on where you're at. But they are an evidence-based and highly effective and cost-effective primary health care initial point of contact for many health systems. But if you're driving along a road and you are looking around and you're saying, oh my gosh, nothing's happening here, there's no health system, you will drive right by these folks and you won't know what they're doing. You won't realize how important they are and how effective they are because they look extremely different. And we process a lot of data based on how things visually look. So when we're used to looking at and seeing places that look like the place on the left, when we see a place or we land in a place that looks like the place on the right, our brain makes conclusions, and those conclusions are often problematic. And so the conclusions that are made often exemplify this deficit orientation, this oversimplification cause fallacy. They result from, in part, our task-oriented culture, which we're going to talk more about, and they lead to misinterpretation of what's helpful. So these are examples, these are talking points from actual global health experiential organizations' websites that are telling students what is going to happen, and also students' testimonials of what they did in low and middle income countries when they came from the US. So the organization is telling students that they're going to change lives, and these are 2 to 4 week trips. They're telling students that they're going to help create sustainable health systems. Again, and these are mostly undergraduate students. The students are or the organization is saying that pre-med student volunteers work with the on-site community health workers to empower community members with sustainable public health clinics. So when you think about what they're saying that pre-med students coming from the US are going somewhere to empower local community health workers. So if outsiders are empowering a local person or a healthcare worker, then what positionality does that outsider have in comparison to that local health worker? By definition, if you are able to empower someone else, you are holding a degree of power that is above someone else. A pre-med student's testimonial about their experience was, we were able to suture a patient whose left hand got caught in between his horse and a fence. In the US, would a pre-med student be suturing a patient in a clinic? Why or why not? The student says, we will do the work one brigade at a time until one day communities we serve can thrive on their own. So what positionality is that student taking in comparison to the community, and how essential this student is visiting for, again, a period of weeks in terms of leading to a community thriving? The last is a quote from a student. Seeing the children's faces light up into the most beautiful smiles at the sight of a sticker, it's indescribable. So just reflect on those comments, on the sense that it gives you, on the power and positionality of different stakeholders. Versus, what if you saw this picture and I told you these things? What if I told you that this community recently got a new clean water source that cut diarrheal illness by 35%? What if I told you that there's a new factory half a mile away that's cut unemployment in half and has increased employment amongst women? And that more women working has led to more disposable income, which has led to increased health-seeking behavior, because women, we know, when in control of resources, will increase health-seeking behavior for their whole family, cutting the time of onset of febrile illness to healthcare encounter by 48 hours, that has resulted in a 12% reduction in mortality and created new business opportunities, which is the laundry hanging in the back corner there. What if I told you that a cooperative has been launched in this community in the last 5 years that implemented a cook stove project and reduced indoor cooking by 60%, and which in turn reduced pulmonary disease by 80% over a 10-year period? What if I told you that economic prosperity resulted in an increase in 40% of the children going to school because school fees could be paid? And what if I told you that the increase in socioeconomic status also increased girls and women's access to menstruation supplies and increased retention of girls after the age of 12 in school by 52%? And what if I told you that birthing kits and formal relationships between the Ministry of Health and traditional birth attendants has reduced maternal mortality to levels equal to that of Black women in several US states? So what is the difference if I'm telling you these messages versus if I'm telling you these messages?
Well, one is asset based. You're
Yes,
looking at the
exactly.
assets. Yeah.
Thank you. You had perfect timing. So the initial slide shows a deficit orientation. It shows the tendency for us to psychologically focus on what is lacking, problems or gaps, or things that feel wrong in a differently resourced place, or a place that's culturally incongruent or contrasting with our frame of reference. So the anecdote to that is asset-based thinking, engagement, and development, which I'm not going to go into a lot of detail, but you can Google it. abcdinstitute.org is where a lot of resources are held. But there is a development framework called asset-based community development that counteracts this deficit orientation. What's another thing that's happening here is the oversimplification cause fallacy. The oversimplification cause fallacy is a psychological phenomenon that when we assume a simplified explanation for a problem. So for instance, the students who are saying, we're going to keep going to this community for 2 weeks a year until they can thrive on their own, they are seeing themselves 2 weeks a year as being the solution to a community thriving on their own. That is oversimplification. That's oversimplifying the cause and the solution. Another thing that gets in our way as folks who are presenting a majoritized culture from the US is that we're coming from a task-oriented culture. So CFHI partners with an organization called Aperion Global, and you can see there 5 dimensions of culture. And I've plotted the bell curve for the United States, the bell curve for India, and the bell curve for Ghana. There's 5 different dimensions there, but one of the dimensions is task orientation versus relationship orientation. Those of us that have been acculturated and socialized in the US tend to have a task orientation, which is where we put value on getting a task done, and you build relationships, trust, and respect by getting things done. This is different than relationship or socially oriented cultures, where you have to build relationships and socialize to build trust and respect, and productivity comes secondary to those social interactions and the relationships. So when we have a task orientation, those students who are saying, like, we're going to go here and do this, we're suturing, and so we're helping, we're doing XYZ, these actions on the behalf of outsiders, these tasks are their primary focus, rather than the relationships and deep understanding with and of community members. Another thing that gets in our way is what we do based on some of these, I would say, disordered or non-constructive ways of thinking, which is that we misinterpret what's helpful. So due to our conscious and unconscious bias, due to the psychological tendencies of the brain, which I mentioned, we are socialized, and due to socialized messaging around power, privilege, superiority, we first need to learn about reality and reprogram ourselves in a deep way. Otherwise, we try to help before we learn deeply about reality. And then our help is packaged in ways that is inappropriate, non-constructive, can even be damaging or harmful. That's very hard to do. So how do we do these things? Well, one thing we do is we go to an evidence-based framework. So this is, I think, in contrast to what the students were saying from that organization that is poorly designed, this is actually looking at data, and it looks at how we can reduce the global burden of disease by 2040 through different types of interventions. And you can see here the different percentages based on these different interventions. I will also point out that none of the data and evidence from this or from Human Resources for Health programs more broadly for every country and for the globe heavily rely on outsiders, particularly students or even outside professionals coming into a place and acting as clinicians or acting as immediate band-aids. This is generally only appropriate in humanitarian crises in very well thought out ways, but it is not a solution for the global burden of disease or longitudinal health systems, which is what is needed. So number one, we go to the data and we learn what actually works. Number two, we shift our assumptions. So we go from a framework of certainty to a framework of curiosity. We move from a position of agents, outsiders as agents, to outsiders as learners. We move from a perspective of exceptionalism and thinking that we have solutions to a framework of humility and realizing that we don't know what we don't know. Even what we know, we actually don't know because it's not always applicable, as Kim was saying. We move from a framework of superiority to inferiority. No longer am I transplanted from being a doctor in Idaho or California to being a doctor in a low and middle income country where I'm not from, as someone who can do better or even do the same as local colleagues. I never practiced clinically abroad. Why? Because my training and my practice is not translatable to 99% of other settings. I work up strokes in a certain way. I work up infections in a certain way. I treat infections in a certain way. It is based on the resources that I have available, the medications, the pharmacy, the essential medications that I use, not that of somewhere else. It's based on the culture of my health system, the culture of patients that I work with, and those that help me work across cultures, but it is not translatable. We move from simplification to complexity. We move from deficits to assets, looking at strengths, capabilities, and capacities. And we move from critic to admirer. Rather than saying, like, this is what's wrong, and oh my gosh, why are you doing these things this way? We go, oh my goodness, like, so much is happening here with little, what looks like little to us, right? So much innovation, so much value, so much cost effectiveness. that we admire what is going on rather than criticize it. An approach to this, which I want to point out for education and higher education in particular, is fair trade learning. Fair trade learning and the community-based global learning collaborative is where this movement is housed. If you want to go to their website or Google it, it actually came out of service learning and undergraduate kind of community engagement work, as well as even tourism and voluntourism. But it was basically an effort to say, we need to structurally change how we partner and how we run educational programs in order to walk our talk and even ideally leap our talk. So fair trade learning recognizes the value of all stakeholders. It rebalances power and privilege, and it calls for co-development and mutual ownership from partnerships within a relationship structure. It challenges existing assumptions of what the problems are and what the solutions are, and it counteracts many tendencies of U.S. culture, institutions, and approaches to this work and engagement. So I'm going to go into more detail about fair trade learning, but I want to pause and ask you, how does this terminology of fair trade learning or the concept of fair trade land on you? In what ways is it useful? In what ways is it challenging?
Please feel free to unmute yourself. Dr. Kovac, are you able to talk? You're heavily engaged in working with our partners. I'm wondering how this strikes you, this idea of fair trade.
Oh, well, thank you. I'm finding your discussion very, very interesting, because I've always come to the thing of the concepts of global health education versus medical missions. And I mean, if I'm understanding kind of what you had with medical trips seem to be more task oriented, where global health education is regard to relationships. So, I mean, it would seem that with regard to fair trade learning, would it seems to be to me more what I try to do, or with more of global health education. And I guess I'm still learning how to do that better, because in the places that I've been, primarily like through Ghana, it's a complex system, and I think she's mentioned about having mutual ownership from partners to develop bidirectionality. I guess that's just with the comments, but from what you're saying too, these principles also can be applied to the host country coming to the U.S. Is that correct? Or do you, with regard to bidirectional learning, that fair trade learning, it should be bidirectional? Is that not correct?
Absolutely. And I think bidirectional can take many forms. One is that like more bidirectional exchange where people are able to travel and transplant themselves in both directions
Mobility.
or multiple directions. Yeah, mobility. I think the other way that it takes shape is recognizing the benefits that the outsider gets, because oftentimes these activities are framed as a benefit for host communities or communities that are perceived as lower resource. But in reality, oftentimes the outsider is getting a lot, whether they're getting research papers or they're getting attention from, their nonprofit groups, or they're getting status in terms of status professionally or personally. They're getting to travel to new places that's paid for. I mean, there's a lot of different things that outsiders are getting. So I think it also, that bidirectionality has to do with being very transparent and authentic about, and the other thing I'll just mention is like innovation goes in multitude of directions. So we used to call it reverse innovation. Now I think because that's kind of implicating that innovation happens between high income to low income. Reverse innovation is low income to high income. Reciprocal innovation, multi-directional innovation, like just recognizing that there's a ton we can learn for our own health system, and that we are not doing things well for a lot of our community members, and countries that have universal health care, which is most of them. You know, there's a lot of different things we can learn. So I think that bidirectionality can take many forms, but I totally agree with what you're saying. And I think the difference between what we used to call international health and global health, I think, is in part this difference of confronting these critical discourses and wading into the challenges of prior constructs that were more colonial.
Dr. Abebe,
Yeah, that I think, as I've said, working with Dr. Heading actually has made me aware of a lot of things that I was not aware of. And I think he's the kind of person who exemplifies humility, working and being committed and providing more sustainable program to the parent country rather than just make a trip and then he's very transparent in how things should be done, and tries to create a more economically sustainable solution instead of just keep on going and back. I was like, how do you make the people that actually work there, help their community and actually also help us in the US? Like, there are things that we don't see because infections don't go the full course. And what happens if we don't do that? We're doing research both ways. So I like the fact that it's reciprocity. So whatever you do in the other parent country would also help the United States and the world, the developed world, because who would see the end result of properly untreated osteomyelitis, amputated leg, and a whole lot of different things. So I like the fact that he's very deliberate and committed to providing students the experience to go there, students coming in, fellows coming in. So this bilateral relationship and, like you said, a sort of fair trade reflects, on that and kind of builds a trusting, long-lasting relationship between the programs.
Thank you for that. And I want to just point to Alexa's comment too. As a non-healthcare provider, to me, it creates equity in recognizing we all bring knowledge, value, and contributions. And I think that's, that cuts across any discipline, any endeavor, but just democratizing that knowledge and redistributing power and privilege. So Peter Singer said more often there is compromise between expediency and ethics. And when you think about task-oriented cultures, and that tends to also go along with direct communication styles and orientation, oftentimes we have timeframes and institutional realities or personal realities that make us have to do things fast. So we have to intentionally and pedagogically slow ourselves down and reframe things. And that's where I think fair trade is really helpful, because it gets it very granular into what we're doing, the different domains. And by no means just the folks that created this or have had input into it, this can be like added to, this is a starting point, not a finish line. But the domains that they've looked at so far include like common purpose, like have you co-created common purpose for what you're even doing and what this partnership or program is about? Host community program leadership, meaning is the community or those individuals that are in traditionally lower resource settings, are they leading, and how so, and how structurally? So it's not just like being like, you're the leader, but it's actually like, we're going to compensate, you're going to be compensated, your travel is going to be covered, you're going to have a title, all the things that we do and expect for ourselves, making sure that happens. Rights the most vulnerable. So in communities, there's power and privilege dynamics within communities everywhere. And not looking at like a singular person you know somewhere else as representing everyone in that community, recognizing that there are going to be folks, oftentimes those that have less voice, that you're not necessarily interacting with, that are more vulnerable, and how are you recognizing that and protecting those folks. Host community program participation, so that goes to that bidirectionality and making sure that people have mobility and can participate and reap the benefits. I will say that virtual infrastructure has really helped this too. Theory of change. So what's the theory of change for the community that you're supposedly helping, quote unquote, and what's the theory of change for students? What's the theory of change for the institution where the students are coming from? So like KUMC, thinking about that. What's the theory of change for faculty involved? Recruitment and publication. So I showed you that bad actor and kind of how they're talking about their programs. So, you can't just like recruit through a frame of exceptionalism and superiority and then be like, but when you get in the country, we're very ethical and humble, like this starts when people even learn about a project or a program. Like, how is it talked about? How are people being recruited to it? How are publications being shared, and authorship and variety of things? Communication, how is that happening? How are we recognizing cultural differences and how feedback happens? Learning integration, how is integration and competencies being developed? Local sourcing, environmental impacts and economic structure. So are you putting drugs in a suitcase and bringing them in? Are you purchasing them locally so that you're actually benefiting the local economy? Clarity of commitment and evaluation. How are you defining that? How are you sharing and checking in? Transparency, which happens in so many realms. And then partnership, not program, meaning that you're prioritizing relationships. The rubric, I'm not going to go through each domain, but the rubric actually has you go from entry level to ideal. And again, I think CFHI is undergoing a process where we're actually customizing this for our organization with our global team. So this is, one group's thoughts on this. And so it's a starting point, not a finish line. And it goes through all the different domains. So I will stop there and invite comments, questions. I see a hand up.
Go ahead, Dina Kawantan.
Yes, sorry, please, can you go back 3 slides to the, yes, here, the Fair Trade Learning Rubric. I like all of these. I think when it's very inclusive. But one of the things that I think I have observed in going to all the places, and I just came back from South Africa for after a month stay there, visiting different rehabilitation settings and everything. It's the culture of the people.
Mm.
It's very important because I think it actually underlies all of the things that you have listed here. And I like the part that you ended with, which is partnership, not program. I think what is also very critical is the sustainability of whatever things we are lucky to work on, and how can they use local resources, local policies, local culture, and all those things within their environment that tend to affect all of this gets done. And I have been really surprised by how culture changes things and how well-meaning interventions, well-meaning activities can simply go south of the border simply because culture was not taken into consideration.
I love that. And I think, the social model of health was a concept in the late 1990 or early 1990s, late 1980s. And I think when you look at the social model of health, I think a parallel that is the social model of interventions, and culture is one of the overarching influences. And so you can have an intervention that works in other communities or evidence-based and works in a laboratory or works intuitively, But if you are not taking into account those contextual features, which includes culture, it will fail, as you mentioned.
Exactly. Yeah.
So I think that that's a really important call out. Dr. Kovac, did you have?
Yes, thank you. I really enjoyed the discussion. And especially, I think a word I heard was voluntourism. I believe you said. I guess a question I have is related to like the difference of medical missions versus global health education. And while I respect missions and what they do, I myself have not been on a medical mission because all the times I believe in education, partnerships, global health education. I guess my question is, and I'm also looking at your slides that you had with regard to fair trade learning rubric. How of the individuals that go to mission trips, which while they're intensive with they get there, I think what I found maybe take less preparation than as compared to global health education. How do you see there a change in the approach of global health education to mission trips, or how can one educate or the people that go on mission trips of the value of global health education? And is there perhaps a hybrid that those that go on mission trips should also be doing global health education?
Yeah, I think mission trips and missions in general can take many different forms. Some of them are aligned with best practices that are more contemporary, and some of them have not integrated best practices that have kind of come up in the last 10 to 15 years. So I think you have to look individually at how different initiatives are run. In many countries, when we say mission, I think there's a faith-based connotation there. In many countries, mission hospitals and mission health systems and faith-based institutions are really a backbone of the health system for a variety of reasons. And often those that have faith-based ties are able to get funding, and there's infrastructure where people stay many, many years in one location, and they're actually running or working with a longitudinal health system, and that's locally staffed along with outsiders. So I think it's important to recognize the role of faith-based institutions in health systems around the world. At the same time, the term medical missions and what some people call duffel bag medicine, this same thing happens outside of faith-based institutions. It happens within academia, it happens within secular nonprofits, it happens, but I think the medical missions terminology has that faith-based connotation. So I just want to say that I think there are a variety of institutions that run poorly designed programs that haven't caught up with contemporary standards. And there's also a lot of work, there's subsets of work within faith-based circles and within medical missions to basically adopt the same frameworks as global health. Global health was defined and came about as a field because academia didn't feel like it had a framework with which to really create, promote more evidence-based, rigorous international health. There was this kind of legacy up till when global health was defined. So I think it is in contrast to medical missions in some ways, but I also think that poorly designed things go under the auspices of global health as well. It's the devil or the grace is in the details.
Thank you.
Yeah, I appreciate you bringing that up. We actually have created some of our own partnerships, one being Dr. Corin Tanger is actually on the line, but plastic surgery has a partnership in Guatemala, and they interface with the local doctor like throughout the year. So there's constant patient through telemedicine. So there's Dr. Corin Tanger, would you like to speak a little bit about your model?
Yeah, and thank you so much. This is a fantastic talk. You know what, the thing that we've been sort of building in Guatemala really comes off what Dr. Mani Mani, one of my mentors, built at KU over the years at CMC Vellore in India, where it is that bidirectional. And the problem that we've all had, because we've all been involved in surgical trips. I'm a plastic surgeon, so we've all been involved in surgical trips. And years ago, it used to be, you know, sort of a volume thing, and it was very much what you were talking about earlier. So our goal with this is really to provide that bidirectional service and provide the follow-up. So we have the same physician who is at the hospital. We're in, you know, regular communication with them. We go there generally twice per year, but there's sort of a whole series of different groups that go as well. So one of the things that Kim and I sort of tried to do when we were first looking at the site a number of years ago was, you know, trying to hook up with some of the universities in country to see if we could assist with some specialty training as we go along. It's not something that has really come to fruition just yet. COVID sort of got in the way, but it is still sort of a long-term goal. And, you know, that's a lot of what, you know, Dr. Heddings does and Dr. Kovac with, you know, trying to learn from the host country and host regions, and then also, you know, see what they need that we can help to provide.
Yeah, I really appreciate that. And, you know, one useful terminology for that is beads on a string, like where you're having kind of the continuity and building of multiple teams coming over time. And I really appreciate the call out of how you transformed, you know, a more parachute surgical approach to a more sustainable one, and that local capacity building, you know, and working with universities is an appropriate offshoot, because ultimately, you know, the goal is to build capacity so that outsiders aren't having to come in the same
Right.
way. And there's always opportunity to learn. I mean, there's bidirectional opportunity to learn. Like, it's going to be infinite, right? So I don't know, like the whole teach Amanda Fish thing is a little bit insufficient to me. So there's going to always be opportunity to learn, but the question is like, who leaves with knowledge and capabilities at the end of the day that are ideally more locally centric. So I know we're coming up on the top of the hour, and I know I'm standing between you and a buffet, so I don't want to do that. But this is my email and our website, and it would be great if anyone has questions or comments. I'm super open to following up, and I just want to thank you again for having me.
We are, oh, go ahead, Dina, come one time.
Dr. Everett, I want to say a big thank you. It's been an excellent presentation. And seriously, to have someone like Dr. Abebe join from the beginning to the end, it speaks volume of the quality of your presentation. This guy is always on the run. So I want to, on that note, say a big thank you to everyone who has attended this meeting, Rich, Dr. Kovac, Dr. Greiner, everyone who's been on the call, Dr. Waxman, everyone, Samuel, everybody, thank you very much for your time. I know there was one other big presentation that was to take place today, but we will move that to the next meeting, and we'll look forward to seeing all of you then. Over to you, Kim.
Thank you. Actually, we didn't have anything else planned for today. Sorry for any confusion on that.
All
But
right.
I would just like to remind everybody, you've heard of the Pillars of Global Health, the education modules that we've been promoting. Dr. Everett, that is CFHI, the organization that she represents. And so if you have not already signed up or registered for the pillars, just shoot me an email and I'll give you that information. And thank you to all of you, as Dina Kimwantan said, thank you for attending. Dr. Everett, thank you so much for your support and your partnership with KUMC. It means a lot.
Yeah, and thank you as well to Kim and Alexa for always doing a good job putting all of this together. Thank you very much, everyone.
Thank you. Be well.
Thank you.